Hey, good afternoon, everyone. So, thank all of you for coming to this afternoon. I will say this is the 9th time I've done this, and the common theme is when we're awarding money, the attendance goes up. But thanks for those of us who are joining us online as well. What we're going to cover today are some of the things that we usually do in this kind of talk, which is recognize new leadership recruits to our campus, faculty who've achieved extraordinary recognition, and then review what we did over the past year compared to what we said we were going to do in terms of our priorities. And then traditionally we talk about the trajectory of the school here. And last year we looked at the 5-year trajectory of how the school is performing compared to ourselves. I'm going to give you a brief snapshot of how we compare to other schools across the country. So you have that perspective. A talk about some of the things we faced this year, and then we're going to finish up by announcing on behalf of the campus and the chancellor the awardees for the Anschutz Acceleration Initiative, about which I'll say more when we get there. So this was a big year for leadership recruitment. We have 3 new clinical department chairs who joined us, two of whom are walking up the stairs there. Yuri Agrawal joined us to lead the Department of Otolaryngology, Head and Neck Surgery. EF Kamal to lead the Department of Radiology, and Barry Mascaro to lead the Department of Dermatology. In addition, last year I botched his introduction, so I put David D. Gregorio up here again, now that he's here with us full time. Amy Gardner, who I'll say more about in a minute, and Jared Converge is succeeding Dr. Allison Kemp, who so ably led the Accords program since its inception. We had 2 distinguished professors recognized by the university this year. I think there have been a total of 144 across all 4 campuses in the history of the university. And Sean Colgan from the Department of Medicine and Frank Degree, the former chair of family medicine, achieved that high distinction this year. Congratulations to them. So a year ago, I stood up here and said we were going to focus on a number of things, and these were 4 of the bullet points from that slide last year. Made much better looking than my slide last year, thanks to Chanti Na and his communications team. And I'm going to talk first about our focus on faculty well-being and engagement. I think it's no secret around the country the burdens on the healthcare workforce, the stress people feel, the burnout that people feel in their jobs is a national epidemic, and one that we need to address. We did a survey in 2022, and we've had a number of initiatives since then, some at the departmental level. A lot of those are listed on this slide. Really focusing on trying to improve the work environment, trying to reduce administrative overhead, and being more conscious of showing appreciation about our fellow faculty and staff. At the school level, we're going to talk in a minute about some of the faculty and leadership development on the next slide. I'm happy to announce that Chancellor Elliman and the campus leadership approved a change to our parental leave policy. That used to be you had to be employed here for a year before you're eligible for paid parental leave, and now people are eligible from day 1. And that was a priority of our family-friendly advisory committee that's led by Drs. Nicole Christian and Annie Moore. And I'm happy we're able to put that into place. We are far from done on this work, and as part of our attention to this, we were fortunate to recruit Dr. Amy Gardner from Baylor. Her background is in actually industrial and organizational psychology. And she will take over the leadership of the Academy of Medical Educators and work on leadership development and mentoring programs. I will say in passing here, as you're going to see later in this presentation, we have grown tremendously, and to the point where we have several departments with well over 1,000 faculty members now. And when you're that big, the department chair's main responsibility becomes similar to my responsibility, which is mine is to recruit good department chairs. Theirs are to recruit and develop outstanding leaders to lead various parts of their department. So we're going to do another faculty survey. We do them at a cadence of about every 24 months. Those of you on the faculty here should have gotten the first of what are going to be a multitude of invitations to participate over the next couple of weeks. We are surveying all the faculty on the School of Medicine payroll and all of the residents and fellows. As I'll mention in a minute, there are 2 surveys tailored to different audiences. And the timeline is as you see here. We're going to be doing the survey now. We should get the results back in March and early April and start to analyze them and try to draw some conclusions, start sharing them with department chairs so that they can develop a communication strategy and a response to issues that arise on that. And then, fair warning to everyone here, because I got in trouble for this last time, the survey results will be posted so that all the faculty can access them early in the summer of this year. These are the QR codes you can scan. There's one for people who are in training or clinically oriented faculty, and there's one for people whose primary activities are research or non-clinical activities. The next priority was to work with our partners at Children's Hospital and University Hospital on quality and safety initiatives. We were in year 2 of our quality incentive program in partnership with University Hospital. And with the support of Tom Grotto and Peg Reilly, the team at University Hospital, led by Jen Weiler, has made substantial progress in the metrics. As Tom is tired of hearing me say, that the ones that doctors can contribute to are all getting better. And most importantly, mortality. And similarly at Children's, they have gone through some reorganization of their quality and safety leadership structure, but dramatic progress over the past calendar year, particularly in circular line associated bloodstream infections, which have been a point of focus for those efforts over the past year. My favorite topic, LCME reaccreditation. So I think I mentioned last year we are starting the process for LCME reaccreditation. There's a couple components to this. The students get to survey themselves and then tell us what we're doing wrong. And that survey, I think, is completed, and the results are going to be shared. We have the cleverly named data collection instrument due this fall. Our last submission was just under 500 pages. I anticipate this one will be larger. So we have 13 working groups that are working on the 12 standards and then the branch campus to prepare that. And I want to thank everybody who's participating in those activities. It's likely that an area of focus is going to be the fact that we're in a new curriculum. We're graduating the last students who are in the legacy curriculum. Next year, 2025 will mark the first graduating class of students who have spent 4 years in this new curriculum. So I anticipate we will be asked to provide follow-up data about those classes. And as you know, we have a relatively new branch campus in partnership with Colorado State University. And given that we had to provide ongoing reporting about our branch campus in Colorado Springs last time around. I anticipate we'll have to do that again this time around. I want to thank Bonnie Kaplan for the thankless job of leading this effort. And if she emails you, please answer and do what she asks you to do. Next, we had talked about the Aurora Wellness Community and our desire to start a primary care practice that met the unmet primary care needs in the 3 zip codes around this campus. And I'm happy to report that we are this close to finalizing a lease agreement for a clinic site a couple miles south of this campus. We hired Dr. Kelly Robinson, who has extensive experience working in a federally qualified health center environment, to be our medical director, and she starts 3 weeks from now. And we anticipate late first quarter, early second quarter, opening that clinic up to see patients. Last year, we also talked about longer-term goals. And first, I'm going to talk about the fact that with our partners, the goal is to create and sustain high reliability programs of clinical excellence. And I'm just going to pick one because otherwise we'll be here until 10 o'clock tonight. And I'm going to talk about our multidisciplinary cancer clinics because I think it is a unique practice here in the state of Colorado. You can see the list of organ systems and their associated cancers that are treated with this clinic model. Some of you who participate in these, this will be a familiar model to you. Multiple specialties, gathering at the beginning of the session to review cases, review the pathology, talk about a collaborative treatment plan, and then engaging with the patient in one visit rather than a series of visits. And you can see on the top sort of the traditional path for a patient who's been diagnosed with cancer to get to the start of treatment, and the fact that we cut that time by more than half with this model. And for patients who have been seen elsewhere who present here for a second opinion, just under a third of the time, about 30%, we wind up with a treatment plan that's different than what had initially been recommended. And so the proof of this is in the pudding. If you look at the results, this is for all stages of cancer, and compare how the patients cared for under this model do compared to the general population in Colorado and to the nation. You can see that in all cases we're better than those statistics, and in some cases, particularly in liver, lung, and pancreatic, we are remarkably better than the state and national statistics. If you look at people who come here because they have a really bad problem, that is stage 4 disease, similarly, you can see if you compare ourselves to the NCI SEER database, and for those of you who aren't in oncology, it's surveillance epidemiology and results, a national database. You can see that we consistently outperform the general experience for patients in the United States, in some cases by a dramatic amount. So not only is it a better patient-focused experience, but there are much better outcomes for our patients. And this has not gone unnoticed. These programs have secured a lot of awards and recognition. I want to thank Wells Messersmith, for whom I stole all these slides, and Rich Schulich, the head of our cancer center. So a point of pride here, and one of many on this campus. The other thing we talked about was advancing our program in personalized medicine, and I'm going to provide 2 examples from that here, and then one is we talk about research discoveries. So if you look at our patient registry formed in collaboration with UC Health, I want to thank Steve Hess and his team for all of their work on this. They've been fabulous partners. You can see that we are approaching 250,000 patients who have provided consent to participate in the registry of biobank, and we've genotyped just under 100,000 of those people, and returned results to 39,000. I think when I gave this talk 2 years ago, we had 6 drugs in our pharmacogenomics panel. We are now up to 31. And we have a pilot that I'll talk about going on in the GI oncology practice. So traditionally, if you send somebody off for genotyping, this is the report you get if you're a doctor. Not particularly helpful if you're sitting in front of a patient trying to decide what drug to prescribe. And what this program has done in collaboration with Steve and his IT team at UC Health has put into EPIC a best practice advisory, so that when somebody has an actionable genotype for the particular drug that you've decided to prescribe, this pops up and gives you an easy to access option to change that prescription decision and provides you the rationale for doing it. So I think this is the future of medicine. Real-time embedded clinical decision support while you're with the patient to take advantage of all the information that's available in the medical record. The GI oncology pilot here has just rolled out a few weeks ago and is a different pharmacogenomics panel than the standard one I just alluded to earlier. And so we're going to walk through the course of an imaginary patient here. And this patient is being referred to oncology because she had a screening colonoscopy and was found to have a colon cancer. And at that time, the oncologist gets one of those alerts I just showed you in EPIC that suggests that they order the GI oncology genomics panel. Those results return, and we'll come back to that in a minute. And this patient goes off for surgery, has a partial colectomy. The path comes back that suggests that there is a high risk for recurrence or dissemination of this tumor, and she's referred to an oncology practice. And after discussion with the oncologist, they decide to do adjuvant chemotherapy. And it turns out that I ran a TCAN. She has a genotype that means that she slowly metabolizes it, and if you prescribe the normal dose, she would be at high risk for toxicity, and the dose is reduced by 30%. Unfortunately, she still develops nausea and vomiting, not unusual with this chemotherapy. One of her other genotypes suggests that she would not respond appropriately to the usually used antiemetic, prompting a change to an alternative agent. So I think our goal over the next 5 years for this program is to be able to move from impacting a relatively small number of patients to impacting a very large number of patients. The other longer-term goal we talked about last year was moving faculty research discoveries into clinical care. And a big leap forward for us on that you heard about from the Chancellor in his talk was the commitment from the Gates Foundation, and we need to express our gratitude to Diane Gates-Wallach and her brother, the late John Gates, for a substantial commitment of $100 million to launch the Gates Institute. And we were able to recruit back Terry Fry as the inaugural director. Under the umbrella of the Gates Institute includes the Gates Biomanufacturing Facility. And if you look at the trials that are going on this campus now that are the result of the work of our faculty that use cells that are engineered in the Gates Biomanufacturing Facility, we have 4 open now and 1 about to open. 3 of those are in adults. CAR T cells, chimeric antigen receptor engineered T cells primarily focused on B-cell malignancies. And you can see there's 2 of them there, one targeting CD19 and then a bispecific one targeting CD19 and CD22. Similarly, a similar CD19 trial in children with B-cell malignancies. and about to open a 19 by 22 trial in children as well. And I think this is one of the strengths of our campus. We have an adult hospital partner, children's hospital partner. Traditionally in oncology, these drugs are rolled out first in the adult population, way before they get tested in kids. And we have the opportunity here to do them simultaneously, which I think is a great strength of ours. The last early phase clinical trial I want to mention is in this young woman, Grace White, who's in her probably now 13 years old. Grace has an unusual, as in there have been 20 reported cases over the last 50 years, genetic disorder called posterior column ataxia that's associated with retinitis pigmentosa, a blinding disease. And the program at Children's, in collaboration with a research lab at the Children's Hospital of Boston, was able to identify the mutation in Grace and develop an antisense oligonucleotide, which is now being injected in her eye on a regular basis to, in hopes of preventing further vision loss in her. And she's about 3 months into this now. So far, so good. So pictured with her in the middle there is Emily McCourt, who's the chief of pediatric ophthalmology at Children's and the one who is taking care of Grace. So now I wanted to give you a sense of where our school sits in the national landscape. Last year we talked about the phenomenal growth on this campus over the past 5 years. But I think it's worthwhile to think about how we compare to other schools around the country. And so the next 3 slides you're going to see, there are going to be yellow boxes on each of those slides. You're not likely, some of you are a lot younger than I am, so maybe you can be able to read the numbers in those boxes, but I want you to look at where those boxes are in these graphs, because that's us, the University of Colorado School of Medicine. So in the last year, we've hired 533 new faculty, and you can see the numbers there. We have almost 3,000 volunteer clinical faculty who play a pivotal role in our new longitudinal integrated clinical curriculum. I anticipate that we'll add the same number of people this year at the rate we're growing, which means that the chaplain's going to have to build another new building. This graph, this table compares us to all medical schools in the United States. The far left-hand column is the number of medical students we have, so you see we're at about the 75th percentile. The other columns are faculty members. So you can see that we are in the top decile for total faculty, clinical faculty, and basic science faculty, compared to 144 other medical schools across the country. This slide is about the money. I'm a dean, so we have to talk about the money. And this compares us to all the public medical schools in the U.S. So you can see going across the bottom, in most of these columns, there are 89 schools in this data set. And without going into what each one of these columns are, you can see that we are in the top decile for everything. Practice plan revenue, research revenue, philanthropy. Thank you, Scott Arthur, and your team. We don't do so well in state support. And the interesting thing here is, despite the fact that we are so large, we are still growing at a rate faster than 85% of the schools in the United States. So a large growth rate times a large number is a large number. That is indicative of what most of our challenges are, and they are related to growth and the growth in the clinical demand for services on this campus. This is another look at our research funding, and I draw your attention to the right-hand side of this slide. And you can see we have a fairly diversified portfolio of where the money comes from. Again, with the notable exception of our state support, we are right at the bottom of the country in the amount of our budget that comes from the state of Colorado. And that is unlikely to change. So we're big. We are, in the parlance of the AAMC, we are a large public research-intensive medical school. And if I look at the numbers through the first 6 months of this year, we will probably grow another 8 to 10% by the time we close the books in June. So I'm going to talk for a moment now about partnerships with the community. I'm going to take a couple of examples here out of many. The first is a partnership with the Cherry Creek School District called the Traverse Academy. This is actually a physical building constructed by the Cherry Creek School District. Went over budget, and they secured an earmark from Jason Crow in Congress for the last $1.5 million to finish it. I did not appreciate this about the Cherry Creek School District. It is much larger and much more diverse than I think I had in my head. Has a significant number of kids around Medicaid. As you can see there, a little less than a third, but 30% qualify for free or reduced lunch, suggesting they come from households with very low income. Like every public school district in the country, they have a lot of kids who are experiencing mental health problems. And so they put out a request for proposals. I want to thank Ron Lee Liao and Neil Epperson and the whole team at psychiatry for leading this effort. They were selected by the Cherry Creek School District to be the partners in this program, which opened up in October. And you can see on here that Cherry Creek does the teaching, and we provide a lot of the behavioral health care and recommendations. The goal here is to keep these kids in the school environment and still learning, get their problems effectively dealt with, and then return them to the regular classroom setting. It's an unmet need here, and I think probably in every school district across the country right now. The other partnership we have is with the Aurora Public Schools. Now, Aurora, like many municipalities, including Denver, has areas in the town with a declining public school enrollment because of the decreased number of children of school age, and have been faced with the difficult task of closing schools. One of those is the Parish School, which is about 2 blocks from here. And so our Aurora Wellness Community, Lisa Rays, in addition to starting the clinic I mentioned earlier, has joined this group called the ABC Collective, and the other partners are listed here, and was recommended by the Aurora Public School Superintendent to be the programmers for the repurposed Parish School and turning it into a community center, including resources for child care, a food bank, and other programs designed to help the people start to address the social determinants of health. That still needs approval by the Aurora Public School Board, so which is not always an entirely rational process. So, but we're hopeful that we'll be able to bring that program online this year. And I'm going to close this part of the presentation by talking about one aspect of serving the community, and that's our partnership with the Agency for Healthcare Policy and Financing, otherwise known as Colorado Medicaid. So in 2017, with the help of the then CFO, now University President Todd Solomon, and Jane Shoemaker, who was our Senior Associate Dean for Finance and Administration, we applied for a federal program called the Upper Payment Limit, which was created by the federal government to be awarded to the faculty of public medical schools to increase specialty care access for patients with Medicaid. And this was based on their observation that because of the reimbursement structure for Medicaid in most states, most community-based specialists either don't see patients with Medicaid or restrict the number of Medicaid patients that they see. And you can see since the onset of this program, which has an economic model like Medicaid, so it's matching funds from funds we put up as a school. We've had a dramatic increase in the number of patients that on Medicaid for whom we provide care. So now we're over 160,000 unique patients. It's 1 million visits a year to our practice overall. As you probably know, at the beginning of this year, roughly 25% of the state of Colorado was on Medicaid, and roughly 50% of the children in Colorado were on Medicaid. Those roles increased during the public health emergency because part of the conditions of the public health emergency is once people were on Medicaid, they could not be disenrolled from Medicaid during the public health emergency. And we have achieved the goal of increasing access to ambulatory care. We have about doubled the number of patients we see in our specialty practices, and with a corresponding increase in the number of visits. The good news is Medicaid patients wait as long as other patients to be seen, and our practices. The bad news is those waits are too long for both those groups of patients, and that needs to be a continued focus for us. So in addition to providing provider reimbursement, a little more than half of these funds are devoted to programs that are designed to improve the health of the population, but for which you normally don't get good clinical reimbursement. And there are right now about 60 of these programs that we have started and provided funding for. There's about 13 listed on this slide as examples of that. Some of them are like ECHO, reach out across the state to educate the primary care community about how to provide better care. Others target very specific populations, peripartum mothers, infants at risk or who are born with to mothers with addiction problems, kids with asthma in low-income neighborhoods who benefit from home visits, a whole array as you see on here. To date, since we started this, we've invested almost $190 million in these programs. So that's federal money invested in these programs that would not otherwise be coming to Colorado, and for whom no other entity in Colorado is actually eligible for this program. So it's had a substantial community impact. So what are our upcoming challenges? So we've talked about the first two a lot over the past couple of years. Trying to make people feel better about coming to work and being proud and enthusiastic about the place in which they work, despite the fact that our hospital partners are full almost every day, and that there are long waiting times to get into our clinic. So when I started these talks in 2016, I said, we were the best kept secret in Colorado. We are no longer the best kept secret in Colorado, and more people want to come here for their care. And that's a challenge that we need to figure out how to meet effectively while making a satisfying career for the people providing that care, both among our faculty and our partner hospital staff, including the nursing staff. I think we're all committed to making hospitals safer and improving our outcomes, and we've made a lot of progress over the past couple of years, but we have a ways to go to be where we all want to be. I think we all want to be at a place where when one of our family members or friends gets admitted, we know they're going to get not only the best care from the most expert people, but minimal risk of harm while they're getting that care. The last one is something that we probably haven't talked about since before the Affordable Care Act, and that is the potential for a rise in the uninsured population in the state of Colorado and the stresses that's going to put on our hospital partners and on our practice. So I mentioned earlier that during the public health emergency, you could not disenroll anybody from Medicaid. This spring, the federal government changed their policy, severed that requirement from the public health emergency, which subsequently sunsetted anyway, and told all the states that they were required to revalidate people's eligibility for Medicaid as a condition of getting the enhanced federal match that they've been experiencing during the public health emergency. So across the country, a lot of people got kicked off of Medicaid. And in Colorado, that number is about 18% so far. And if you look at the actual numbers, it's about just under 350,000 people have lost Medicaid coverage. And if those 350,000 people were now in households that had jobs and access to commercial insurance, my hospital partner sitting here in the auditorium would be very happy. We would be very happy. But if you look at it, the majority of those people were kicked off for technical reasons, not that they didn't meet eligibility criteria. That combination with the Hospital Discounted Care Act that was passed more than a year ago by the Colorado State Legislature has resulted in a rising tide of patients who are presenting for medical care who don't have insurance, and many of whom are disinterested in figuring out whether they're eligible for Medicaid. So more to come on this, but this is going to put a lot of stress at a time when most clinical systems across the country are not faring nearly as well financially as they were 3 years ago. And most places aren't going to be able to afford to take care of large numbers of uninsured patients. So before we get to why most of you are here, one last plea. Please fill out the faculty survey. Ask your colleagues to fill out the faculty survey. I'm proud of the fact that we continue to attract great talent from across the country and from within our own training programs. I hope I've shown you that we are a unique resource in the state of Colorado. We remain the only academic medical center, the only NCI-designated comprehensive cancer center, the only CTSA in the state. We have great clinical outcomes, and the word is out now, so that lots of patients want to come here for their care. So despite the fact that we're really large, and I think it was 3 or 4 years ago that I stood here in front of you and said that we were going to plateau soon because we couldn't keep growing at this rate. I was wrong. We're keeping growing at this rate, at least for the foreseeable future. All right, so now for the fun part of the talk. So first of all, I want to acknowledge the extraordinary support of the Anschutz Foundation and the Anschutz family for this campus during my tenure here as dean. They've been fabulous partners, have shown a lot of faith in the potential of this campus, and invested in a way that's enabled us to dramatically accelerate our growth and our impact across the state of Colorado and the region. I want to thank Ted Harms, the director of the foundation, for being here today. As you all know, the middle of last year, the foundation committed $50 million of funding to fund translational research initiatives that we thought would have a meaningful impact on patient care. And so we sent out a solicitation for letters of interest, thinking we'd maybe get 50. We got more than 3 times that many. And in a display of weakness, I decided we couldn't read 150 full proposals. So we cut that field in half and wound up eventually with around 60 full proposals. We narrowed that group in about half and then invited a panel of outside experts to come in, independently review those grants and make recommendations for funding. So it's my pleasure on behalf of the Chancellor and the NHS Foundation to announce the recipients of those awards. But first, a caveat. Not everybody's going to get all the money they ask for, so more to come on that. And originally we thought we'd be able to fund 5 to 7 awards with that kind of money. We were actually able to fund 9, and that's because of some co-investment from other partners that I'll mention when we get to those awards. I'm going to present these in alphabetical order, so one should by the last name of the principal investigator. So one should not infer a rank order in this list. So first up is Dr. Mary Mascari and her project implementation of personalized skin cancer screening using genetic and clinical risk factors to identify a high-risk subgroup. The second on the list is Dr. Kemper Soler from the Department of Ophthalmology, retinal transplant to restore vision in patients with macular degeneration. And for this one, I want to thank Terry Fry, the Gates Foundation, and the Gates Institute for co-investing in supporting this research initiative. And that same thanks goes out for this award. Eduardo Davila and his Mighty 88 platform. For those of you who are not in that field, this applies to tumor-infiltrating lymphocytes as a therapy for solid tumors. The Mighty 88 platform for enhancing cellular cancer immunotherapy, and once again, the Gates Institute is a participating investor in supporting this. Next is Stephen Mundowitz from the Division of Gastroenterology, who had a very interesting device proposal in a project transforming GI cancer care from inpatient surgery to outpatient endoscopy. Next is Joaquin Espinoza, who's leads the Sarnik Institute. And on this one, I want to thank John C. and Michelle C. Whitten at C. and Global Dance Foundation for providing support for part of this clinical trial. This is immunomodulatory therapy for Down syndrome, which is basically a randomized trial of JAK inhibitors in young individuals who have trisomy. Antonio Jimeno, targeting protein translation and elongation to treat cancer patients. Jayashri Kalpathy Kramer, so ophthalmology is a big winner in this today. Dr. Kalpathy Kramer is a professor in the Department of Ophthalmology, and the project is oculomics as a biomarker for comprehensive and non-invasive patient health assessment. Dan Matlock and his team for making personalization the standard through rapid design, implementation, testing, and maintenance. And these are clinical aids for patients facing treatment decisions in a variety of conditions. And then from the School of Dental Medicine, Jeffrey Stansbury, multi-material 3D print processing of antimicrobial and antifungal dental prosthetics, aka dentures. And those are the 9 awardees. I want to thank you all for your attention, and that concludes the presentation. Thanks very much.